welcome to the Preemie Chats. Preemie Chats is our weekly educational session for healthcare professionals and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Bacchini. I am a Preemie parent and Executive Director of the Canadian Premature Babies Foundation, as known as CPBF, and I'm happy to be your host today. CPBF is a parent-led charitable organization that helps families in and after the NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a family or a healthcare professional, please check our website, canadianpreemies.org. There you'll find resources, the latest project, and most importantly, a community of people who wants to see our little babies thrive. And if you're watching this live session today, please bring your voice to the table. Leave comments and questions in the chat, and we'll try to address them during our program. It is through rich conversations like this where we can advance practice and learn together. So please participate and let us know where you're watching from. And today we're going to talk about miracle babies, getting parents and healthcare teams in the same page. And I have here joining me live from Winnipeg, Manitoba, Dr. Michael Narvey, who will discuss the challenge of matching parental expectations in time of crisis with what healthcare teams are able and prepared to provide. Dr. Narvey is the Section Head of Neonatology in Winnipeg, Manitoba, and Medical Director of the Child Health Transport Team. He has been a committee member of the Canadian Pediatric Society Fetus and Newborn Committee, and since July 2018 has been its chairperson. Dr. Narvey also joined our Scientific Advisory Committee here at CPBF a couple of years ago. And Dr. Narvey, we're so grateful to have you here today. It will be certainly a very difficult and exciting conversation today.
Absolutely. I'm delighted to be here, and it's nice to see you again.
Thank you. So recently you saw on the news the story of the most premature twins born at 22 weeks and 0 days, who just turned one a couple of weeks ago. The story has created a lot of conversation among our community. It has raised concerns, some ethical debates, but also a lot of hope to others. And we want to unpack this situation today as more and more centers around the world are working towards saving extremely preterm babies. We've seen 21-week babies going home in US, and many centers in Canada now are saving 22-weekers, such as the ones at Mount Sinai Hospital, the twins that we just talked about. So Dr. Narvey, let's start talking about how parents are involved in this decision in such a critical time.
Yeah, this story really made the rounds. You know, I have to say I received this story in many different ways via email. I received it through social media, people reaching out, lots of attention to this. And what made it so sensational was that the parents, as you know, presented just prior to 22 weeks. And your question is really pertinent to this situation. And the reason why this generated so much discussion was because, as you know from the story, initially they were told no, we're sorry, you're too early. I believe the presentation was at 21 weeks, 5 days. And you're right that most centers in Canada now, and I've actually done a survey of this, virtually every center in Canada now offers resuscitation at 22 weeks. What differs by center is whether they have that written as a document, like a guideline or a standard operating procedure, or whether this is an informal thing. I don't have the breakdown of the percentage for you handy, but suffice to say, some centers formally have that approach, other centers don't. What is also common in Canada is that the question becomes, what do you do with steroids? And I'm going to tie this back to the parents in a moment, but steroids, as you know, are given as 2 doses 24 hours apart. So at least here in Manitoba, our approach is to say, we will start giving steroids around 21 weeks and 5 days, recognizing that if we're offering resuscitation at 22 weeks, then we need to give them the best opportunity, which would mean giving them steroids so that they're ready to go for resuscitation if the family chooses at 22 weeks. So how does the family's decision play into this? So I'm going to give you an extreme, and I'm going to say, I don't know if there would be much argument if a woman or a pregnant person appeared at a hospital at 18 weeks and said, I want everything done. I think there's not a hospital in the country, after confirming the gestational age to be accurate, that would say, we are not in a position to offer anything. We're sorry, there's nothing you can do. And we can play this game, but given that we only have a certain amount of time, I won't go by week. But if I was to ask the same hospitals, well, what about a 19-week? What about a 20-week? What about a 21-week? At some point, you're going to get someone that would start to say, well, and that generally is going to be around 21 weeks. Why is 21 important? Because you mentioned already that there are places in the United States. We saw on CNN last year, there was a survivor at a year of age who had been born at 21 weeks. And they, much like the case here, once they made it to a year, they sort of celebrated this, saying, look what happened. The problem is in this example that I'm going to give you, and then it'll illustrate why parents need to be involved in these decisions. Medicine is not an exact science. And what I mean by that is, let me paint this picture for you. What if a woman comes in, to take an extreme, at 21 weeks and 6 days at 11 o'clock at night? She is about to undergo a precipitous labor. She's going to deliver any minute. Would you deny a request to resuscitate? Well, the answer I would hope would be no. That, common sense would prevail, and you would say, you know what, I'm in Winnipeg, so in Toronto, she's already 22 weeks, right? It's that close. But to take it a little bit further, the best gestational age dating we have outside of IVF, where you pretty much know, but if you have a first trimester ultrasound, or you have a certain last known menstrual period, the best gestational age dating, according to the ACOG or SOGC, is about plus or minus 5 to 7 days. Okay. So to me, there's a little bit of arrogance, and I hope this isn't too controversial, although this topic is controversial, that if a mom comes in at 21 weeks and 5 days and says, I want everything done, there is the possibility that we must entertain that what if she's actually 22 and 3? What if she's actually 22 and 4? Are we applying a very rigid, concept of a clock, to a very uncertain situation? So I think we have to keep that in mind. Now, before I get myself into trouble, and I'm quoted as saying that I advocate we should resuscitate all 21 weekers, no, that's not what I'm saying. But what I'm saying is we have an obligation, as per the CPS, the Canadian Pediatric Society statement from 2017, we have an obligation to share the most accurate information we can provide with families who are trying to make a decision about what they want to do. These are immense times of stress. No one is thinking clearly, but it's our job to share with them, based on their stated gestational age, what the odds are for survival, what the odds are for significant long-term morbidity or disability. And if in spite of that, you had a family that said, I hear you, but I still want everything done, then I would say, as a medical team, we get into a challenging situation, because I guess I would put it this way. The mother and father in this news story presented at 21 weeks and 5 days. While the hospital in question said, I'm sorry, there's nothing we can do, where they presented and they were taken to one that ultimately said, okay, we can do something, and it wound up being 22 weeks and 0 days. There are hospitals that would have done the same. Some would have said very prescriptively, I'm sorry, you're not yet 22 weeks. And others might have said, you know what, how certain are we really? So I think that, the Canadian Pediatric Society, and I would be remiss if I didn't acknowledge, and you did say that I'm chair of the committee, so of course I support their statements. But the strength of that 2017 statement is the shared decision model. And the shared decision model, as I mentioned, means that it's not a paternalistic approach of a doctor meeting the family, holding their hand and saying, I'm sorry, there's nothing you can do, period. Within parameters, like I said, younger gestational ages, they're, even if you're out at 5 days at 20 weeks, it's still too young. But we have to respect that some families, when they hear the information, will say, yes, my dates may be a little off, but given the results at 22 weeks in this country, I don't think it's worth trying. Other families may say, doctor, can you please try? And I'm going to quote Annie Janvier out of Montreal, who I once talked to, and she's presented this. And one of the things that she points out is that one can always stop. We don't know. When I go into a labor room and a baby is about to be delivered at 22 weeks, I don't know if this is a survivor before birth. I know the statistics. I know about 30% will survive, but I don't know which 3 out of 10 will. So another approach is to say, and this is what they do in Sweden, the presumption in Sweden is that you are going to resuscitate. It's almost like an opt-out approach. So they are very pro resuscitation. So the argument would be, if most babies who are not going to survive at these young gestational ages will not survive or will die in the first 24 hours, which is what Annie pointed out, why not try? If the family wishes, try, and then if things are not going well, you can always withdraw.
So you said so many things that I want to just ask some questions, because not everywhere in the world there is such a thing as called shared decision. Correct. So let's talk about shared decision. How does that look like in that moment? Because it is a very, as you mentioned, very stressful time for everyone. Right? Parent is in labor, sometimes unexpectedly labor that early. Sometimes you know ahead of time that you have a chance of delivering that early. So how is that moment? How is that conversation? Is it taking into consideration the family's religion, their values, their cultural background? Or do you feel sometimes depends who the clinician or the physician on call is going to have their own bias on the situation? Because we are all human beings, let's be honest, right? You all have our opinions on one point or the other point. And I heard in many conferences, why are we doing this? So what is your take on that? And let's unpack a little bit of this shared decision for people who are not used to that term, or to include parents in this kind of decision.
So I think, all great questions. It is, to be human is to have biases. We all have biases. I'd be lying if I said to you that I'm not impacted by the last patient that I saw. If the last patient I saw had a horrible outcome and the family was to say to me, we made such a mistake, we shouldn't have even started, for example, it's not going to be something that one does not carry with them. We're human. We're impacted by stories. What we have to protect ourselves, though, is, again, in the CPS statement, and I can say in Manitoba we've adopted this as well, is the concept that let this not be a decision or a recommendation that is a unilateral recommendation, meaning the obstetrician and the neonatologist need to meet, need to talk about the individual patient and their circumstances before making any recommendations. The idea of having the two of them come together is that they can balance each other. So if I've recently had a bad experience, which could cloud the language I use, if I talk to the obstetrician and they say, well, just to remind you, we've taken a proactive approach to this and we're offering resuscitation, I think that helps. But I think we also owe it to the family to be honest. So for example, you will not always offer resuscitation. So if I believe, based on all the evidence I have, that a child has 0% chance of survival, and this happened recently, at best it was 30%, and this child had multiple other problems, which were already in a term infant going to decrease dramatically the chance of survival. So if I know that exists in addition to 22 weeks, that's something you need to tell the family. That yes, we can try, but you know what trying means? Trying means that if things aren't going well, we start pushing on the chest. We may break ribs, cause a lot of bruising, pain, right? And if ultimately the outcome is not going to be positive, is there a point in doing that? And some families will then choose to say, you know what, let's not. So shared decision making, and this is an important thing, doesn't mean you're sharing the decision to go forward. It means you're sharing the decision as to what's going to happen. And in some cases, it's we will do nothing, but nothing means compassionate care, bundling, doing footprints, having the mother and father hold their baby and letting them pass. Sometimes it means full resuscitation, and sometimes it means exploring the family, as you say, religious background, values, their belief system. And sometimes you meet in the middle. So sometimes you come up with something that feels good for the family. What you might say is, you know what, let's resuscitate, but we can provide positive pressure with a mask. We can give oxygen, but you know what, if we get to the point that we need to compress on the chest, I don't want that. If we need epinephrine, I don't want that. It's a higher power or fate determining whether or not this is going to be viable or not. So I think so shared decision is not just whether you go or don't go. It's what are the wishes? How does the family want to respect the life that is about to be put before them? And what will feel, it's not going to feel good. Nothing ever feels good. But what is the best way to manage this situation? And the last thing I'll tell you, Fabienne, is sometimes what I've said to families, and I find this is a very powerful statement, which I guess sounds arrogant, but I mean, the feedback I've had is families appreciate it, is you're often in these situations entering into an environment where you have a total loss of control. Mm-hmm. Your body seems to be working against you for reasons that you have no control over. These babies are coming out of your uterus much earlier than expected. And there is an opportunity here to empower families to take some control of the situation. So in a situation where they feel they have absolutely no control, what I will say to families is, I'm offering you the opportunity to take a little bit of control back here. I can't stop this delivery from happening, but you can make some choices that are going to be in the best interest of your baby and your family. And that's what we try to do.
And this is really empowering, because when I was in labor 26 weeks, I had one still birth and Gabriel's coming out alive. We didn't know how. We were just giving stats. We are not, I mean, also because at 26 weeks, there's no such a conversation about whether you're going to resuscitate the baby or not, because it's the survival rate was high even 10 years ago. But I wasn't part of that decision. I never felt. But when I was giving the stats years later, when I go back and I reflect on that moment in time, I was being asked to make some kind of a decision but I didn't know then. But it was totally out of my control. We just heard what can happen to my child if he makes to birth. So it was such a difficult moment, but I didn't feel I was involved at all. But so I'm happy to see this shared decision happening in many places, in Canada specifically, and having these guidelines from CPS. But we have a question from our live audience, Robin, asking, in coming to a shared decision, and she corrected, do you take parental health literacy into account when delivering your message to the family? That's a great question.
Yeah, that's a fantastic question. The answer is, I would hope everyone tries. Another way of asking that question, or a related question, is, do you take literacy, just pure literacy, or understanding of the English language into account? Because that's a frequent issue, is someone has some English, but how do you know what they are really receiving? Mm-hmm. And so I think, one needs to ask for feedback, when you are conveying information, rather than just saying a bunch of statistics and then saying, what do you want to do, and walking out of the room. To close out that interview with the family, it's a good thing to just ask them to say, okay, what is your understanding here of what we've just agreed to? Are you comfortable? Do you have any questions? Is there anything that doesn't make sense? I will tell you, Fabiana, I don't have the journal article for this, but there was a Canadian study done some time ago, years ago, and it looked at, because you mentioned data, it looked at the provision of data to families in antenatal consultation, quoting this rate of BPD, this rate of a PDA complication, mortality, morbidity. And you know what? It doesn't matter. Parents, possibly could be health literacy. It could be the state of their ability to receive information at that time. But what was found in that study, looking at antenatal consultation, was the two things that truly went into a decision were, number one, and you mentioned it earlier, religion was a strong motivator. If your faith says life is precious, you must fight to save it, period. It doesn't matter what the data says, you're still going to try. And the other thing was gut instinct, was just, it was in spite of all the data, it was, do I just feel that this is the right thing to do? So I think that that's been helpful in antenatal counseling, because I will admit, when I started off, I used to pile on all the data because I thought families wanted to know. Now, if a family wants to know what's the chance of survival, by all means, that's important. And certainly at 22 weeks and 23 weeks, a family has the right to know that we're not talking about a 95% survival. So in any event, that's the answer. And I see there's a comment again.
Yes, it's a good point. Patient family literacy and health literacy is something we are only recently addressing in the US at the beginning of medical school level. So thank you, Robin. But you mentioned about data and what is really important for families. Going back to Annie Janvier, she does have another article where she's counseling parents, and the parents, all they wanted to know if their baby was going to be able to have sex and help them making pizza because they have a pizza place. So the families, sometimes the outcomes are very different than the outcomes that you're looking for, right? And for me, when a lot of people say, well, my son has, it's not a good outcome because he has quadriplegic cerebral palsy. For me, it's a great outcome because I got to bring him home.
Yeah.
So I think independent of his medical challenge, which we have many, as you know, because you know me for many years now, and his disability, it is an incredible outcome for us. And I think the joy that he brings to our lives, the love that we have for him, it's not tangible. It can be measured in the data. And I think that is something that we should sometimes take into consideration when you're talking to families, because this piece is never really addressed?
Well, I mean, Fabiana, you would know this literature, I'm sure, pretty better than myself, but there's actually been a fair bit of literature that looks at this topic of quality of life, because that's really what you're talking about right now. And physicians and other healthcare team members, when you compare in studies where they watch a video of a ex-preterm infant who's now 18 years old, watching them go around their daily activities, or lack thereof, perhaps. When they are asked to rate the quality of life as they perceive it, it is less, it's worse than the patient themselves and often their parents would view. And in part, that stems from, it's a natural thing that we do, because what we do is we compare our lives to what we're seeing on the video. And we say, oh my God, if I had a child with quadriplegic cerebral palsy, that would be awful, right? Like, that's how we look at it. But when you have brought that child home, and that's all you've ever known, and looking at the child doesn't know any differently, right? Now, sure, they may be aware enough that they can look around and they can see that their brother or their cousin or their friend is walking around and playing basketball and doing all these things that they can't do, or do well. But if they have never known anything differently, you won't be surprised, but people listening might be surprised to learn that these people often think, my life's pretty good. They don't, well, I mean, there of course will be some that wouldn't, but on average, they will score their quality of life higher than we would.
Absolutely. You're going to a completely different debate on our own views of disability that we could leave for another day, because I have a lot to say on that piece alone. But I want to go back to you when you did mention Sweden before. And I heard in a conference a few years ago, they were resuscitating 100% of the 22-weekers. But was also the debate that Sweden give parents a 2-year parental leave for both parents. And their healthcare system is really equipped to support those families in the community, which is not quite the same here in Canada, as you know, right? Like, our families struggle with care in the system many years during the childhood, with therapies, with a lot of different ways of caring for the child. Is this something that the system should be looking at as we going lower in the gestational age, saving those babies at a much lower age, perhaps with some morbidities, some more disabilities? What is happening to the system? Is our system going to be equipped to care for these children? Because I can tell you, here in Ontario, we have a lot of gaps in the system. And one parent has to stop working a lot of times because it's the life is overwhelming with appointments, and the child is sick all the time and has a lot of hospital readmissions. So how are we going to work together to make sure the families have the support they need? And the schools as well, because we also have a lot of issues with preterm babies in the school system.
Well, that's a $1 billion question. It's not $1 million question. I think that where they're right now, I think, is a disconnect. And I shouldn't say, I don't know every jurisdiction in Canada, but for example, in the decision to go to 22 weeks as the point of viability, of course, there has been consultation with departments of pediatrics, the hospital. One needs to look at things like, and this is the truth about healthcare, there's a finite number of resources. So you need to look at, what is the expected survival? What is the expected length of stay? Does our system have the capacity in the hospital to handle the increased patient days? And fourth, if we start doing this, are there things we won't be able to do? So, for example, if occupancy is going to be up by 5%, and we anticipate that we're going to have to deny admission, and we're going to have to, send babies to places they wouldn't have otherwise gone, could there be any downstream consequences from that? But this is all part of the healthcare stay. But to my knowledge, government has not been brought into that conversation to say, knock, knock, are you aware that we're going to start to see, let's say, 5 to 10 22-week infants a year? These 22-week infants are going to stay in our hospital system for about 6 to 9 months, potentially. And are you aware that a very significant number of these children will have problems with their lungs, exercise tolerance, may need physiotherapy, occupational therapy, may have cerebral palsy, may have reduced quality of life. I know I just said it's, variable, but reduced dependence on medical equipment and services. And this child who survives may have a lifetime cost. If I've seen this estimate, if you have ROP and you have blindness, at least in one eye, I think that the total loss of productivity and cost put all together is estimated to be about $1 million for a child. So have we solicited the opinion of the government and said, this is what we're doing? Do you want to forecast needs in the community? That piece I don't think is there. And I think if you really want to make change and make sure that you're prepared, not just within the hospital, but so that this new legion of babies that are going out there have care in the community that they need. Because otherwise, and you've just said it, why are kids coming back for frequent readmission? Well, some of them are coming back because they are medically fragile. Let's say they have reflux and they're prone to aspiration pneumonia. That's not the fault of the system. That's just inherent to them. But what if there are things that could be done? Access to physio, access to OT, access to a dietitian, access to lactation consultants to support weight gain in the community and the benefits of breast milk. What if we don't have all those things in place? Some of these readmissions could be avoidable. And so this is all very, broad, but I think that's where maybe Sweden has it. Sweden has a lot of the support that you're talking about. But I also think, going back to the comment on Sweden has all of that. But what Sweden has also showed us, and when I talk about 22 weeks and presentations I give, I often mention Malcolm Gladwell and the 10,000 hours. And nobody likes to talk about this. It's a bit taboo, but I'm just going to say it because it's the truth, is that when you look at the outcomes for Sweden, not just their survival outcomes, but their long-term outcome, BPD, ROP, cerebral palsy, neurodevelopment, they're much better than most other places. And there's, not to knock on Nationwide Children's, but they just happen to have gone up in a paper. I think it was 2019 or 2018, comparing the outcomes for a selective approach at 22 weeks, which was Nationwide Children's, excellent hospital, to Uppsala, Sweden, which had this universal approach. The outcomes are much better in Uppsala. And one of the reasons, I think, is when you look at the total number of patients during the same time period resuscitated, much higher in Sweden. And the more experience you have, the better off these kids become, or the better the chances you become, because look at what it does to your team. Mm-hmm. If I only resuscitate 2 babies a year at 22 weeks as an individual neonatologist, how good could I possibly get? But if I see 4 a year, I'm seeing 1 every 3 months, some of that attention to detail, that nuanced care will be fresh in your mind. And guess what? What's also been found is the more 22-week babies you resuscitate, You get better at 23 and you get better at 24 and better at 25. Because Fabiana, I can tell you, this is the honest truth. It used to be not that long ago that if I heard a 24-week infant was being born, my blood pressure probably went up. Okay, because I thought, oh my God, it's 24 weeks, it's gonna be crazy. I mean, of course we care, but I don't have that same reaction anymore when I hear there's a 24-weeker coming, because I think, oh, okay, well, we've done 22 and 23, so 24 is an older baby now. So that there are these benefits to having this proactive approach. But going back to your original comment, yes, without the community support, it's difficult to have a smooth discharge and success.
Absolutely. We have a comment here from Lauren. She's looking at more of the lifespan. Also need to consider potential blood pressure issues, diabetes, CKD, help with the acronym, mental health, neurodivergence, etc. And the list sometimes seems endless in adulthood, which cover the span of gestational ages. So thank you, Lauren, for your comment. So you talk about the teams that sometimes they see two babies a year. So with the current scenario now, how are the physicians and the NICU teams when this situation happens in your unit? Is there apprehension, excitement, debates? What is the temperature in well, you can talk about your center, but overall what you've seen around the NICUs?
Well, of course, as you say, I can't speak to other centers because I'm not in them, but I can say that one of the things that I've certainly promoted and others have promoted in approaching this group of precious infants is the can-do attitude. That if we go into this believing it's not going to work, your outcomes are not going to be good. And you've never been on my patient rounds, but one of the things that I'm known for talking about is I often say the babies can feel our positive energy. And because I see, for those that know me, I see the world often through rose-colored glasses when I'm on service. Everything's going to work. I'm always positive. Everything's going to be good. This extubation will be a success, And the secret is, I'm actually not, a magical thinker. I don't really believe that I'm sending waves of energy to the baby. I don't believe that. However, I will tell you this. It is human nature. If you don't believe you're going to succeed, you don't succeed. When you do believe you're going to succeed, at least in medicine, something happens. And what happens is you pay more attention to detail. You respond to things faster. Like if you watch, when someone doesn't believe that a baby's going to survive the night, they're given information by the bedside nurse of, the blood pressure is low. And normally they would react to it, but they go, well, okay, we'll just tolerate it. It's lower than it normally would be and that they tolerate, but now they're just going to tolerate it. If you continue to believe that you can do it, you're going to still react fast. You may wind up in the same outcome, but you'll pick up on electrolyte disturbances faster, blood gas disturbances faster. So I think that positive outlook is what people are really promoting right now. I think that there's a national desire to see us be able to do this, to be able to do it well. But ultimately, doing it well doesn't necessarily equate to survival. Mm-hmm. Doing it well, in my mind, equates to patient satisfaction, if you will, or client satisfaction. We are in a client-based industry, whether we see it that way or not. Mm-hmm. When a family comes into the hospital and meets me, my job is not only to try to get a survivor who's intact and does well. My job is also to set things up such that if things don't go well and the family is put in a position finally where they either choose not to resuscitate, modified resuscitation, full resuscitation that doesn't survive, the family can leave that hospital and they can be content in knowing that they did what they felt was right. and that they will not leave this hospital feeling that, what if I had done this? What if I had done that? Now, of course, they still may wonder that, like maybe they shouldn't have tried, but they will know, going back to shared decision, that their beliefs, their values, their wishes were respected. They got what they wanted. It might not be the outcome they wanted, but they can look themselves in the mirror and say, I don't want anyone to have to say, I didn't advocate strongly enough. Mm-hmm. I should have advocated stronger. I should have tried to resuscitate. No, if I've done my job and the team has done their job right, they're not looking in the mirror and second guessing. Yeah.
Very important points. I did share, if anybody's watching, want to share you on social media here, it's all your handles on Instagram, TikTok, and Twitter. And also I want to share this account on Instagram, 22 Matters, because a lot of great stories of the 22 weaker babies, how they are doing. Is a Canadian, a group of Canadian parents actually that started this account. And it's so great to see how those babies are doing and developing. And I shared the link on the comments, the Globe and Mail story of the twins at Mount Sinai. I think we have one more comment here, Dr. Narvey wants, and then we can start wrapping up. Are prospective studies being performed at 22 weeks to determine the long-term quality of life, disease regression, or advancement and onset of chronic illnesses?
Robin, you are full of great questions today. I can't quote any specific authors that would be working on this, but I can tell you, at least in Canada, there is something called the CN Fund. Mm-hmm. So that's the Canadian Neonatal Follow-Up Network. And you've got to remember, I think you're in the US, you mentioned, or at least you referenced the US. In Canada, our numbers are small compared to the US, about 1/10 the population, but we have the follow-up network. At this point, we don't have enough patients who have been resuscitated at 22 weeks, because remember, we just advocated for that in 2017 in Canada. So in the next few years, we're going to start to see the long-term outcomes. Like right now, I've got a presentation I give where I can show you CN Fund data showing how many babies at 23 weeks have CP, how many babies have ROP and hearing loss and so forth. We have zero data at this point we don't have zero. We don't have enough to publish anything. But I would say as the number of 22 weekers continues to grow and get enrolled into our Canadian neonatal network and then get absorbed into the follow-up network, you're going to start to see publications looking at things like long-term health, developmental outcomes, and so forth. So I'm very excited to see that because to Fabiana's point, it's not just about survival, or maybe you didn't say that, but I'm going to say that. It's about long-term. And while quality of life may be deemed to be better for the person who's living it, we still want to make sure that that outcome is as good as it can be. So we need to be able to provide accurate information. Like right now, where I'm blind is if a family says to me, what is the chance of my 22-weeker having blindness? At least in Canada, I can't say that right now. I can tell you about how many have ROP, but I can't tell you long-term how many are necessarily blind or how many don't, are able to go to grade 5 and not have a teaching assistant. Like I don't know that yet. There is some larger data sets out of the US, but maybe I'm biased. I like to look at the Canadian outcomes for our Canadian patients.
Absolutely. Dr. Narvey, thank you so much for this very interesting conversation today. We have so much more to talk about. And this is for sure something that will be in our radar and bring the data when we have for sure on the 22 weekers. But I'm so grateful that you joined me here today to have this conversation that is not always easy for parents, to hear. It's not always easy for healthcare providers to be on the forefront, making those decisions with family or informing families or sharing that information with families. So I'm really grateful that you agreed to have this conversation today, especially with all the news that came out in the last few weeks and a lot of very important debates in our community. So thank you.
Anytime. Okay.
And to all of you watching us live today, thank you so much for joining this episode of the Preemie Chats. And a special thanks to our sponsor, AstraZeneca, who makes education sessions like this possible for us. And just a reminder that if you missed part of today's session, head over to canadianpreemies.org. Let me share the link here of our website. And to see this episode, but also all the past sessions of our Preemie Chats. You'll find many resources and support options available there. And you'll also be reminded that CPBF is a charitable organization and depends on support to continue its important work. Consider how you can support CPBF in its mission to empower family of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. And I'll see you again next Friday, 1 p.m. Eastern Time. Stay well.